My dear aspirant student, we're meeting on the another session of hematopoietic system. On the previous sessions of hematopoietic system, we discussed iron, vitamin B12 and folic acid plus some hematopoietic growth factors. And you can have a look at the slide. The plan for this session is anticoagulant drugs, that's heparin and warfarin, treatment of bleeding disorders which includes vitamin K and plasma fractions, then the drugs that inhibit fibrinolysis and promote clotting, that's tranexamic acid, EACA and aprocitenine. Next we shall do the thrombolytic drugs, that's tissue plasminogen activator, and next antiplatelet agents aspirin, ticlopidine, clopidogrel and apixaban. We will start with anticoagulants and we shall try to complete as far as possible, and if all these chapters don't get over in this session, probably you will have to refer a new session to go for those chapters. So let's start with anticoagulants. The anticoagulant drugs, that's the anticoagulation in vitro or in vivo. And we shall discuss the in vivo anticoagulants. Rapidly acting is heparin and the newer heparins, that's the low molecular weight heparins, enoxaparin, dalteparin, ribavirin and nitroparin. The slow-acting drugs are coumarins. The most important agent is warfarin. Then you have nicumelon and decumerol. And enantions is phenandione. So let's start to discuss heparin and warfarin sodium. And my plan is to put heparin on left side and warfarin sodium on the right side, so that we can compare between them and we can also know about the individual agents. Before this, the important stages of coagulation. You have already done coagulation in details. I'm trying to split it only in three steps, three most important steps. The first step, as you see on the slide, is conversion of prothrombin into thrombin. In other words, activation of prothrombin. Please mind well, prothrombin is nothing but factor 2. And prothrombin gets activated to thrombin. So I put in the bracket, that's 2A, that's activated factor 2. And on this reaction, I have shown the substances which are going to help the reaction. That's factor 10A, factor 5 and calcium. What I'm trying to do is I'm trying to avoid the details and I'm trying to split it objectively only in three steps so that it's easy to understand. So prothrombin, that's factor 2 getting converted to thrombin. So factor 2 getting converted, getting activated to factor 2A, prothrombin to thrombin. Now the next step we are considering is fibrinogen getting converted to fibrin, and that's the fibrin monomer. And for fibrinogen to get converted into fibrin, this thrombin which was formed at the end of the first step, this is helping. So you see this arrow has come from thrombin here and is saying fibrinogen to fibrin, thrombin or factor 2A is helping it. So now you have the monomer fibrin formulated. Next, you have fibrin monomer getting converted to polymer fibrin. So that's polymerization of fibrin. And out of many substances, two important factors work here. That's factor 2A and factor 13A. So try to memorize this. Prothrombin to thrombin, fibrinogen to fibrin, and monomer fibrin to polymer fibrin. These are the three important stages of coagulation. And you can complete the rest of the coagulation cascade with the help of other steps. We move ahead to discuss heparin and warfarin sodium. As we already said, heparin is a rapidly acting agent and warfarin is slow acting. Heparin is always given parenterally. It's a large molecule, ionized molecule, so you cannot give it by oral route of administration. Warfarin sodium is the most important oral anticoagulant. Yes, it can be given parentally if you want. The most common route of administration is oral. Next, you must have heard heparin is also used in the laboratories as anticoagulant. So, it's an anticoagulant acting both in vivo and in vitro. Whereas warfarin sodium is only used in the human body. So, that's only in vivo. And heparin affects mainly the intrinsic pathway of coagulation, whereas warfarin sodium acts mainly on the extrinsic pathway of coagulation. On the next box, I am going to take you to the mechanism of action to understand the mechanism, and out of this mechanism we also going to derive many applications. First, heparin. What's the primary key point for mechanism of action of heparin? What's that primary target where heparin starts? Look, heparin binds to and activates antithrombin 3. That's okay. Antithrombin 3 is the substance. Heparin binds to it and it activates antithrombin 3. Now you have a complex formed of heparin and antithrombin 3. Now this complex immediately starts the action and goes on inhibiting number of coagulation factors. And have a look at the factors. It inhibits factor 2A, factor 9A, 10A, 11A, 12A and 13A. Look at that. So the action really is spreading everywhere, and the important thing is acting instantaneously, because it's acting or combining with antithrombin 3 and it's activating antithrombin 3, which is going to inhibit all other factors. So this complex antithrombin 3 plus heparin is going to inhibit the complex. If you look at the factors which are inhibited, I think it's very obvious to you. Almost most of the factors are inhibited. It means this particular complex is going to affect almost all the 3 important stages of coagulation which we discussed in the beginning. Just to revise, the 3 stages of coagulation were prothrombin to thrombin, fibrinogen to fibrin, and fibrin monomer to fibrin polymer. So look at this step. First step, prothrombin to thrombin, we said factor 2A, factor 10A, and see the factors which are inhibited. Factor 10A is here. Fibrinogen to fibrin, the factor which helps is 2A. This complex has inhibited 2A, so this step is going to be inhibited. Fibrin monomer to fibrin polymer, 2A and 13A, they are helping. Look at the factors inhibited. 2A is there, 13A is there. Almost all the 3 steps of coagulation are inhibited. So I summarize the action of heparin, the mechanism of action of heparin, as it binds to antithrombin 3, it activates antithrombin 3. The complex of heparin and antithrombin 3 inhibits number of factors including 2A, 9A, 10A, 11A, 12A, 13A in a row. So that's about heparin. Let's go to the other side, warfarin sodium. Warfarin sodium inhibits the activation of vitamin K, and many times it's called the opposite substance to vitamin K, the antagonist to vitamin K. So it inhibits the activation of vitamin K. What is this activation of vitamin K? One of the forms of vitamin K is vitamin K epoxide, and this form generates the hydroxyquinone form. This hydroxyquinone form is the active form, and I've shown the sign of inhibition here. This is the place where vitamin K acts, and it inhibits the conversion of vitamin K epoxide into the active hydroxyquinone form. So what has happened is vitamin K is now not activated, and because vitamin K cannot act, it's the drug warfarin sodium is going to suppress all those factors which are dependent on vitamin K. All those factors which need vitamin K for synthesis, they are not going to be synthesized. Which are these factors? Most important 4 factors are factor 2, factor 7, factor 9 and factor 10. 2, 7, 9, 10. 2, 7, 9, 10 are the most important vitamin K dependent clotting factors which are inhibited. And then the major mechanism of action of warfarin sodium becomes inhibiting the activation of vitamin K and suppressing the synthesis of the vitamin K dependent clotting factors. There is something interesting here. When you give warfarin sodium and it inhibits the activation of vitamin K, what is going to happen is whatever factors are going to be synthesized after this, that synthesis is going to be inhibited. As you know, already you have the coagulation factors present in the body they will keep on acting, which means that it's going to take some time for warfarin sodium to take the action, because whatever factors are already there, they are acting. And until their effect is over, you cannot do anything. You have given the drug, but you will have to wait until this drug starts inhibiting the synthesis of the new clotting factors. For your information, I have written the half-lives of factors 2, 7, 9, 10. Factor 2 is prothrombin. Its half-life is 60 hours. Factor 7 has half-life of 6 hours. Factor 9, 24 hours. And factor 10, 40 hours. Look at that. So even if you gave the drug, there are clotting factors which are already working, and these will keep on working until they complete their action. And just to give you a rough idea, factor 7 has a half-life of 6 hours, and factor 2 prothrombin has got a half-life of 60 hours. Please remember this. We'll explore this fact later on this table. Coming to the next row, we saw the action of heparin, and that was the primary action, activating antithrombin 3 and binding a complex, and then straightway inhibiting the factors which are present. So the action was instant. In addition, heparin produces antiplatelet action. Antiplatelet action. If you go to the other side, warfarin sodium does not have significant antiplatelet action. So if you want to say about their anticoagulant action, for heparin, say the action is instant because it activates antithrombin 3, and the complex of heparin and antithrombin 3 immediately starts inhibiting the factors which are in action. And it has also got antiplatelet action. For warfarin sodium, it inhibits the activation of vitamin K, so it prevents the synthesis of vitamin K dependent clotting factors, namely factors 2, 7, 9, 10. And because the factors which are already present, they'll keep on acting, the warfarin sodium, you cannot expect the effect instantly or immediately. Plus, it has no antiplatelet effect. Let's go to the next slide. Look at the route of administration for heparin is intravenous, and the effect is instant. If you give it subcutaneously, 1 hour will be required roughly to develop the effect, and over next 4 to 6 hours the action will last. For warfarin sodium, look at this. I said we'll explore that matter further. You have given the drug now. To get the best anticoagulant effect, you need to wait for 1 to 3 days, because I told you the half-lives of the factors which are already existing, and the maximum one was factor 2, that was prothrombin, that was 60 hours. That's the half-life. So whatever prothrombin is already here will keep on acting, and you will have to wait until you can see the effect of warfarin inhibiting the synthesis of new clotting factors. So the onset is 1 to 3 days, and you get a peak over 2 to 3 days. So I've written on the next line to elaborate it: heparin onset immediate, no lag, and warfarin time lag of about 36 hours. About 36 hours. That's almost 1.5 days. So there will be a time lag of 1.5 days. The action will slowly develop, and the full action will be developed by 2 to 3 days. Now heparin affects the clotting time. It increases the clotting time. So if you put the patient on heparin, now you gave the last dose and you stopped it. After this, the clotting time returns to normal in 2 to 4 hours after stoppage. Look at that, because its action is instant, and the action will also get over early. One who starts early finishes early, and one who starts late finishes late. It's as simple as that. So heparin, the clotting time returns to normal within 2 to 4 hours. If you go to warfarin sodium increases the prothrombin time. That's a major substance. So if you stop warfarin now, the prothrombin time returns to normal within 3 days after stoppage. Obviously, because its action is slow and it's dependent on the synthesis of the clotting factors. So even if you stop the drug, whatever inhibition it has produced, you have to wait until the factors which are inhibited start working, and that's why you need about 3 days for the prothrombin time to return to normal. How do we measure the effect, and how do we monitor the patient? For heparin, the parameter which is used is activated partial thromboplastin time. Look at this, small a, capital PTT. Small a, capital PTT. Activated partial thromboplastin time. With warfarin sodium, the effect is measured with the help of a ratio called INR, and it is the International Normalized Ratio. Ratio of what? Ratio of the patient's prothrombin time to the standard value of prothrombin time. So each laboratory is going to have its standard value of prothrombin time. So sometimes you go from hospital to hospitals, things can vary, but in the changing world the things are more standardized. So the patient's prothrombin time upon the standard prothrombin time value is defined as INR, International Normalized Ratio, and this is commonly used to monitor the effect of warfarin. Now let's see what happens to these parameters with heparin. Activated partial thromboplastin time 1.5 to 2.5 times, so that's about 50 to 80 seconds, and the clotting time will be about 2 times of normal. For warfarin sodium, when you are using it for prophylaxis of deep vein thrombosis, the INR levels are set at 2 to 2.5. When you are treating a thrombosis, the INR levels are set at 2 to 3, and if it is myocardial infarction or if the concern with the prosthetic valves, then the INR is set between 3 and 3.5. So this is how you monitor, and these are the parameters which are used for monitoring heparin and warfarin sodium. We go to the next point, a very essential point in your clinical practice, practical application. Heparin does not cross placenta. Heparin does not cross milk barrier. So heparin is the anticoagulant of choice to be used in pregnant women. Please remember this. Warfarin crosses placenta, crosses milk, and warfarin is contraindicated in pregnancy because it leads to craniofacial defects, it leads to growth retardation, bleeding, and this is called Contradi syndrome. Heparin is given subcutaneously or intravenously, and there are low molecular weight heparins who have got higher bioavailability. That's enoxaparin and dalteparin. As we already discussed, warfarin is an oral anticoagulant. It is given by the oral route of administration in the form of tablets. The usual dose is 5 to 10 milligrams every day. It's also available by injection. Let's go to the next box. It is describing some important adverse effects of heparin and warfarin sodium. An obvious adverse effect of an anticoagulant is bleeding. So with heparin you can get hematuria. Plus heparin can lead to thrombocytopenia, alopecia, increase in the liver enzymes, allergic reactions, and osteoporosis. Warfarin sodium, again, bleeding, ecchymosis, epistaxis, hematuria, GI bleeding or intracranial bleeding, and same, alopecia, urticaria, dermatitis. Sometimes diarrhea, GI disturbances, and cutaneous or oral ulcers. After the adverse effects, we go to the next slide, and the next slide is telling you that heparin has got less drug interactions. Warfarin sodium has many drug interactions. I hope you know warfarin sodium is a highly plasma protein binding agent and is amenable to displacement by many other plasma protein binding agents. So if they displace warfarin from the plasma protein binding site, more warfarin will be free in the blood and there will be excess effect of warfarin, what you call excess anticoagulation, means bleeding, right? If there is heparin toxicity, how to manage, how to treat? Yes, there is a specific antidote available for heparin, and the name of the antidote is protamine sulfate 1% by slow intravenous route 50 milligrams, plus the patient is going to need fresh blood transfusion. Please remember, you have started an anticoagulant drug and you are getting the toxicity, you are getting the overdose, so the patient will be bleeding. Naturally, first you have to give an antidote, that's protamine sulfate, which will go and combine with the heparin and is going to produce antagonism, and the patient will need fresh blood transfusion. For warfarin sodium, what will be the antidote? we just now discussed in the mechanism of action. Warfarin sodium is going to inhibit vitamin K inside your body. Obviously, if there's overdose of warfarin sodium, the antidote is vitamin K. So you give vitamin K1 oxide, it's called phytonadione, or another form is minadione. So you give vitamin K1 oxide and again fresh frozen plasma or the whole blood. So this is the comparison of the antidotes, and this issue is important for you because you will be facing some objective questions. And which is the antidote for this overdose? How do you treat this toxicity? Heparin, protamine sulfate, warfarin, vitamin K or vitamin K1 oxide. And can I ask you about iron, which we are not discussing on this session, some other session? What's the antidote for iron? It's called dysferrioxamine. So from the chapter of the blood, these three antidotes will be important. Iron dysferrioxamine, heparin protamine sulfate, warfarin sodium, vitamin K. The next box is telling you if there is genetic deficiency of antithrombin 3, what to do. We said heparin combines with antithrombin 3, activates antithrombin 3. But if there is a patient who has genetic deficiency of antithrombin 3, what to do? This patient will be resistant to the action of heparin. What to do then? The answer to this is use antithrombin 3 itself. Straightway use antithrombin 3, and because this patient has deficiency of antithrombin 3, use antithrombin 3. Please remember this. This is a tricky question. What substance you will use as an anticoagulant if there is genetic deficiency of antithrombin 3? There is deficiency of antithrombin 3, so you give antithrombin 3. Next, there is a substance called lepirudin. Please remember this preparation, lepirudin. If the patient has allergy to heparin, then we need an option. Lepirudin is the option for heparin allergic patients. Next, we go on to discuss the uses or the indications for the anticoagulants. Heparin is used for immediate effect, and oral anticoagulants are used for maintenance. So that's the general principle. So if you think of these general principles, in general the indications will be same. You want anticoagulant effect, there will be various conditions on which you need this anticoagulant effect. So the conditions, indications will be same for heparin or warfarin, but if the immediate effect is required, you go for heparin, and for maintenance you go for oral anticoagulant. So is the prophylaxis and treatment, number one, most important, venous thrombosis. And I am writing one more condition, it's venous thrombosis, but you should remember this condition, that's called as deep vein thrombosis or DVT. Third important condition is pulmonary embolism. So in general, all venous thrombosis, to be more specific, especially deep vein thrombosis, and the third most important to remember is pulmonary embolism. So basically, if you think about the indications, I want to say only this much, that's venous thrombosis, pulmonary embolism. But what are the situations in which these things happen? And this is why we are saying the indications in further details, one-step detail, is anticoagulant prophylaxis in high-risk patients. So there are patients who are more prone to get clotting. So we are trying to use this particular phenomenon and trying to describe the high-risk patients. Look, who are the high-risk patients? For one, bedridden and old patients. Next, the post-operative situations. You are likely to have coagulation. Next, postpartum patients after the labor. Next, after the stroke, post-stroke cases. Then, patients with leg fractures. Yes, that's one of the important situations in which the coagulation is likely. Next, the patients undergoing elective surgery or who are immobilized for a long time. Patients undergoing a major elective surgery, or those who suffer from, or those who are on prolonged immobilization. Next, for maintaining the patency of the shunts and cannulae. There may be various shunts and cannulae in the body of the patient, and there can be clotting in these shunts and cannulae. You want to maintain the patency of these, and this is why you might need anticoagulant prophylaxis. Prophylaxis and treatment of arterial thrombosis is the next issue. I never said it in first place because anticoagulants are most effective against venous thrombosis. So I just said venous thrombosis, deep vein thrombosis, pulmonary embolism, over. But now I am adding a detail, yes, for arterial thrombosis, which is the anticoagulants are less effective. There are better agents for this, but you can use the anticoagulants. Number one, myocardial infarction and unstable angina. Then in patients with rheumatic valvular heart disease with the risk of atrial fibrillation, then cerebral embolism, transient ischemic attacks or strokes, and vascular surgeries, prosthetic heart valves, dialysis or DIC, disseminated intravascular coagulation. So all these situations mostly is about arterial thrombosis, and heparin and warfarin sodium, who are anticoagulants, they are less effective for arterial thrombosis. Still we mentioned some of the conditions. So someone asks you, myocardial infarction, what to use? Don't say immediately heparin or warfarin sodium. That's not going to work better. So we have better anticoagulants, for better antiplatelet agents rather are required in those situations. So heparin, warfarin sodium are anticoagulants. They are not antiplatelet. So just say venous thrombosis, venous thromboembolism. After you complete all the list of venous thromboembolism, you can say yes, sometimes they are also useful for arterial thrombosis, but they are less effective. I hope you remember I already told you heparin is the drug of choice in pregnancy and warfarin sodium is contraindicated due to the phytotoxic effects. What are the contraindications? For warfarin sodium, the contraindication is pregnancy, and contraindications for both the drugs is obviously if the patient is bleeding. Bleeding disorders, thrombocytopenia, severe hypertension, threatened abortion, patients who are suffering from piles, patients who already have ulcers inside their body like gastrointestinal ulcers, patients with bacterial endocarditis, large tumors and tuberculosis, they are more prone. Then ocular or neurosurgery, spinal anesthesia, lumbar puncture, patients with chronic alcoholism, cirrhosis and renal failure, and patients who are receiving drug in the form of aspirin, which also has antiplatelet action, so there will be excess bleeding. So these are the contraindications for the anticoagulants. I think it's quite enough, and it was a good class for this particular session. We will stop at this stage and we'll continue the chapter on another new session. I hope you enjoyed. Thanks a lot. Best luck.